So good morning all. We are moving to a very important but most of the time in the clinical practice a neglected topic. Ethics during the ECMO or ethics during ECLS run. So to discuss this panel discussion, I request my panelists Dr. Sunil Paboni, Dr. Venkat Goyal, Dr. Deepanjan and Dr. Kapil Thakkar. Because Dr. Nand Kishore could not make it and Dr. Pranay is at the moment is busy with some preparation for your training purposes. I have nothing to disclose and there is no conflict of interest. So what is the ethical goal? It remains same. When we talk about in the medical practice, it is always same. It's in the best interest of the patient. Every time we have been always taught and we have been always given this idea that this should be in the best interest of the patient. Patient autonomy means decision making by the patient should always be respected. But there should be a way of this autonomy depending upon the land of law, depending upon the social and cultural practices across the world. It is not same everywhere. Informed consent. This is probably one of the most important thing which we have been taught in our medical practice, and especially in this era of litigation, we are too much bothered about the litigation. And that's why we are more focused on the informed consent. So first question before panelists goes to the participants, that what do you feel, what exactly is the informed consent? Any one of you.
Definitely advise it. So that will change our actual consent. If we are saying there is a moderate risk of 50%, then we need more convincing to actually start it. But we have to float the idea there, and then at least they are also prepared, and then it will be an informed consent of all the complications, including of cannulation, etc. So we may put it up to them that there is anyways a very high mortality chance, and this is something which we can definitely try. But the problem we face is that when we say it's a life support system, many a times in India they keep asking us that that means the patient is dead or alive on ECMO. So we need a little clarity there.
Okay. Perfect. So anybody wants to add? Or have some different view? Yes, please.
Informed consent should be, if the patient is conscious, the patient should be told about that. In the case of VEV, before putting an ECMO, we should tell that what we are going to do, what is the complications, or what is the chance that he or she will make it. And that should be signed by a witness. And in case of an VA, where the patient may not be able to give a consent, the legal surrogate or the person who has brought the patient to the ICU should give the consent. Again, we should be explaining what's the cost, what's the complications, and what's the success rate. And again, that has to be signed by a witness.
Yeah, we should follow the same guidelines as in other cases of informed consent in the intensive care unit or for any treatment option as it is. And probably that should include first why it is needed, then what we are going to do, what complication can happen, what other options are there. And then you talk about the cost, you talk about the complications or consequences of not doing this procedure. So all these should be a component of the consent, informed consent, when we look for any ICU procedure, say any surgical procedure, anything, the consent remains the same. So then comes the shared decision making. Shared decision making means the sharing, it is not only a sharing, but basically clinician talks about the clinical aspect, while patients are, in cases of patient is not in the condition to make a decision, then the next kin of the patient, they think about various factors including social, beliefs, or what patient wanted, what kind of a life they are willing for that particular patient. So many factors are involved in the shared decision making. And the basic purpose of shared decision making is that nothing should be imposed on the patient or nothing should be imposed even on the doctor, and it should be more of the without conflicts we are actually reaching to a consensus. Surrogate decision making when a patient is not able to, so we have to understand that here it becomes much more important, because again it depends, most of the time issues are financial. So who is taking care of the patient, how many close kin of the patients are there who can be decision maker if patient is not in a state of making decision. So those things definitely needs to be in consideration. And finally, end of life care, that if patient is, the ECMO is futile, then what next to be done, or what about the advanced directives, if at all any. So when we talk about the principle of ethics, the first and foremost thing is the beneficence, that good of the patient always comes first. And another important thing which we have been taught in the medicine, that non-maleficence means first do no harm. None of our activity should harm the patient, and intent should always be to help the patient. Autonomy I have already discussed, and justice, that when there is a limitation of the resources, that how it should be distributed fairly. So these are the four principles of the ethical issues. But this becomes a big challenge when we talk about ECMO, because when we talk about the beneficence, there are still limited evidences. In spite of we have more than 2,000 run at more than 2 lakh runs as per the ELSO data, but still we have the limited evidences. So beneficence is always challenged, that we are not sure that it is really going to give benefit to the patient. Again, it is a very expensive procedure. So justice, again, it is being challenged. Address for the definition, because if your patient on ECMO and still the heart is beating, which could not have happened without ECMO. So is it death or it is not death? There is always a confusion. So the challenges for the integrity, because patient relatives are always, he is not responding, he is not opening his eye, but is he alive? This is a big question we always listen. Then again, patient is sedated, not in a state to make any decision. So it is again a challenge to autonomy. And most important, non-maleficence is challenged, that this is not a treatment, this is only a bridge, and we have to wait either for the recovery or for a definitive treatment. So this is why these points are raised. We have to be very, very careful when we are choosing a patient on ECMO, when we are making decisions when a patient is on ECMO, or when we have decided that patient is, this is a futile exercise, and how we are going to withdraw the ECMO in this patient. So the current issues, the orders of DNR is there. Now another big question, that who gives the orders of DNRs? Can patient relative give, which most of us are practicing at the moment. It is acceptable or not acceptable, but ECMO is acceptable. CPR is acceptable, but relative don't want that ECMO should be done. Do not intubate, but extracorporeal carbon dioxide removal is acceptable. Do not ECMO orders. What does DNR means when a patient is on VA ECMO? And moral distress, not only in the patient attendant, but to the clinician, as more in the staff who is working with the patient. So let's start with the case. 48-year-old male patient, post-renal transplant with the COVID ARDS on the mechanical ventilation. PaCO2 is 140 with the pH of 6.8. PO2 is 44. He is on the vasopressors, noradrenaline, vasopressin and adrenaline, and a retrieval call was received, and the distance was almost 100 kilometers. So the team reached to the site, and there was one episode of bradycardia. This is what history was given, which responded to adrenaline push. No CPR was required. So once the team reached, the pupils were bilaterally dilated. It was not reacting. So my question to Dr. Puvoni, sir, what will be your approach in this patient?
Vivek, patient is in a very critical situation. Ideally, he needs ECMO, but the concern is about dilatation of the pupils. How is the integrity of the brain? If it is possible to get CT scan done in this patient, that would be ideal. But I appreciate there are practical difficulties in transporting the patient in this critical state to CT scanner and get the CT done. So if it is not possible to take him to CT scanner, I would go ahead and put him on ECMO.
So PCO2 is 140. Most of the patients would have a dilated pupils, raised lactate, all those things will be there. And it is the best interest. The patient never had a complete cardiac arrest. The only one episode of bradycardia which was witnessed and was addressed to immediately with adrenaline, and he responded well. And we can put the patient on ECMO, but explaining the consequences to the relatives, and then we have to be careful while coming down on the PCO2 on ECMO. That's the thing that we have to remember, because most of the time what we falter is that if the PCO2 comes down quickly, we have a bad neurological outcome. And we should not blame it for the previous event, but it is this thing that PCO2 has to be controlled slowly.
Yeah. And moreover, with the hypoxia itself, within 10 seconds, the pupil dilates. Whenever there is a patient that has hypoxic, and our patient is already having a PO2 of so low PO2, so there is a possibility. Yes. So any difference in the group? Yes, please.
My question to the panelists, should we do the EEG for these patients before putting on ECMO?
See, the question is the time. Time is the most essential factor, and most of the time when you are dealing with the ECMO situation, because still ECMO is not well accepted across the society, you get a call most of the time with the multi-organ failures. When everybody feels this patient is going to die, put this patient on ECMO. So patient selection is probably important, and time is also crucial, because you miss that time when you are going for any modality, EEG, you can do it bedside, but it is going to take some time. And when you get an ECMO call, 70% time it's at 2 o'clock in the night. So nobody can do EEG at that time. It is very difficult, very difficult. Sir, any opinion? Yeah, please.
See, if we discuss a particular case here, you received a call from the distance of 100 kilometers. So practically you can do a EEG, there is no contraindications, but what are the goals? See, that question should come in our mind. What are the goals of doing an EEG? Should we think of a flat line on EEG or no brain activity in this case?
Just for the brain activity is there or not?
Because
pupil is bilaterally fixed, we should see the other reflexes also for brain death also.
See, important here is pH. Have you seen the pH? It is 6.
It is there.
So pH is like an currency. When the pH is too low, pupil may not give you a good guide. Second thing, EEG we can do theoretically, no issues, because till the time we reach there, EEG can be done. That is not an deal.
This is for our safeguard. That's why I am asking. If there is some activities there, we can say.
Some reports
because in court of law, anybody can blame on us.
Can be done. Can be done. No issues. But sometimes if you see the results of EEG, so sometimes that will again put us in the other sides.
So the problem that occurs is that in most of these patients, the relatives would then go to some other doctor for a cross check. And most of them would say, "Arey, pupil fixed dilated tha, why the patient was put on ECMO?" That's why we are.
That's why it is important to note it. Here you had received a call, you had not initiated. Till you reach, you have to keep ready a plan. Sometimes you require ECPR in such cases, till the time you reaches there. So it has to be ready, it has to be documented on paper with evidences.
So EEG is time taking and technician is specific. So can we do TCD instead of EEG? And we can show the flow also to the relative.
Anything can be done, but the only thing, time constraint. You have to keep in mind that how much time you have to do all these modalities, and it becomes very difficult. But what is more important, and Dr. Kapil and Dr. Dipanjan was stressing, that all these needs to be documented, to be discussed, because if you don't do it, tomorrow definitely you are going to be blamed by any clinician or anybody that you have not done this. But this, and again, there is no, these are the questions, but most of them may not have the single answer, or they can, this may be right in the particular situation, but this may not be right in the another situation of the same set of the patient. So this is the food for thought, that you should think that what best in your situation you can adopt and you can tailor according to the patient need, patient relatives, how they are approaching, and what is the present situation for you. So this is why there is always in medicine we say uncertainty, and there is always a probability, ambiguity, and complexity. These three things we should always keep in mind, and especially when we are talking about ECMO.
Vivek, I just want to add one word.
Yes, sir.
The sensitivity and specificity of the test you are doing is very important. If you consider the EEG in this case, EEG could be low due to multiple reasons, excessive sedation, something else, anticonvulsants used before, etc., etc. So if the patient needs ECMO and you are denying it due to some other reason, you are not doing justice to the patient.
Yeah.
So the sensitivity and specificity of the test you are planning to do is very important.
True, sir.
Sir, one thing, sir, one doubt.
Yeah.
So regarding, suppose it's a little bit outskirts this case, it is in the city only, and if possible for medical legal issues, can we involve neurologist for medical legal
Definitely.
issues?
It depends on in what situation you are and how good you are in communication and how much patient relatives are understanding what you are saying to them. Because if it is in your own hospital, you can do, but if you are dependent on some other hospital, just think over it that you have reached at 2 o'clock in the night for ECMO and you are asking, okay, call the neurologist, he will decide. And neurologist said, okay, without CT and without EG, I cannot do anything. Will this patient wait till that time? He will not. So this kind of a situation you will come across. If you do ECMO, you will come across very frequently, and this is you who are going to take decision whether it's a successful or unsuccessful. It is solely depends on the situation, right? We can always call, but when neurologist comes, he evaluate, okay, fine, EEG, and EEG, as sir rightly said, that most of the time you get, okay, this is, the impression is moderate encephalopathy, you know what to do. It is not going to help you in any way. So this all depends on the individual patient, individual situation, how old the patient, what are the other clinical situation, what about the other organ functions probably, and what you are looking for. Are you looking for recovery, or this, what is your targets? This all depends on that. Okay, so we move to the second case. 11-month-old child with a septic myocarditis with pneumonia, 21 days on ECMO, and CFTR gene came positive now. And there is a need to change the oxygenator, but parents are now, they are saying we are not willing for this. So again, my question goes to Pubuni sir, what you will do in this situation?
Vivek, with extensive information available on cystic fibrosis nowadays, cystic fibrosis is a disease which can be controlled with a good longevity of lifespan up to 30s to 40 years of age. So we don't take it as a contraindication. As medical personnel, I would like to support changing the oxygenator, inform the parents about the advances that came in the management of cystic fibrosis, and try to convince them for changing oxygenator. So it is about misinformation to the parents if they have got some negative thoughts about CFTR gene being positive with that. So I would like to convince them and change the oxygenator.
Venkat sir?
The disease is a reversible disease, septic myocarditis with pneumonia. So a trial should be done with ECMO to help the patient.
Dr. Depanchat, what to do when patients are not, parents are not getting convinced?
We need to change the oxygenator, so we need their permission. It's in a private sector, so they have to pay the bills. And if they are not paying the bills, with the hospital want to foot it, I don't think so. And if even if it's in the government sector, it all comes very commonly when the relatives know that, but think that it is futile, but you still think that it can be continued for a few more days and wait and see whether the child improves or not. That is a dilemma that we all face. And the relatives many a times say that because of the cost constraints, we don't want to continue. But we all clinicians think that a few more days of ECMO might improve, the patient might improve. So this is one of such kind of thing, but again, a CFTR gene, when it's positive, in spite of all our best efforts, it depends on the parents. If they don't want to continue, I won't be able to help much.
Any other opinion from the house? Yeah.
So I would look at it two ways. The one point is from the family side. Second thing is your colleague's opinion. Here the team matters, team opinion matters. If the genes is positive and family is not willing because of that reason, because the CFTR gene is positive, you should require an expert of it. If I am being not a pediatrician, I'll call a colleague or the expert persons, take his help, we'll ask him to sit when we do a counselings, resolve the query why the family don't want to do continue. If finance is issue, yes, Dr. Deepanjan is right, we can't do more if it is a finances issue, but family is not willing particular because of that reasons, we can counsel them with audio video counselings and recordings.
So the issues, all of them have already addressed. The communication, that we need to communicate, and how to communicate probably becomes more important. Sometimes you need an expert to discuss along with you in this situation. And sometimes you feel that the patient is recovering, then possibly you can accept a suboptimal removal of ECMO, probably you can think of that. And most important is this leads to a moral distress. And we never realize that our staff who gets attached with the patient, especially in the smaller kids, and because they know it, that there is a conflict between the family and treatment, and there is a treatment option, there is a possibility of recovering, so there is always a moral distress amongst the staff as well, not only to the patient and family, but to the staff as well. So the third case, 50-year-old male, severe COVID-ARDS with a PF ratio of 0.5. After 2 episodes of proning and 3 weeks of high flow nasal oxygenation, he was shifted that possibly he may need ECMO because he is not recovering. Only one ECMO console was free. Other machines were occupied with the least chance for getting free for the next few days. At the same time, a 22-year-old patient, amlodipine poisoning, came to the emergency simultaneously after 18 hours of ingestion, and he is in the severe cardiogenic shock. So, Venkat sir, what will be your approach now?
My approach will be to follow the best result, and I find that a 22-year-old amlodipine poisoning case will require a short course of ECMO, and also till the time the 50-year-old male can be tried to be managed on ventilator, and if you don't give ECMO to that young male immediately, then he will not survive. So by the criteria of emergency and by the expectation of results, I feel ECMO should be first offered to the young male.
Dr. Kapil?
So theoretically, I agree totally with the sirs, because for the male, and if you see the durations also in the first case, 58-year-old male, almost 3 weeks on HFNO. He was referred to you for the opinions and for the treatment. He has not referred to you for only and only for ECMO. And still there are other therapy which are available like invasive ventilators and all. So you can try it with it, and we all know the hypoxia can be managed well and patients will sustain for it. And the young male, as sir rightly mentions, the run of VA ECMO will be for the shorter periods. So by the times we will able to win that patients, and God forbid me if need the same patients of ARDS wala patients, we can introduce a VA ECMO. So my choice is go with the young male.
Any other opinion from the house? Yes, please.
So from our side, what our decision is right, but ultimately, the family, their financial status, this matters a lot because
Yes, yes. This is only that whom to choose. This is always a dilemma. That whom to choose first. And in this particular case, the same thing was done. But unfortunately, he did not make out, and the second patient did not require ECMO. He recovered of his own. So,
there's
again,
one ECMO with 2 patients during COVID time. Actually, it was done like
one ECMO
to maintain
in
2 patients
patients.
on single
How?
ECMO.
Amlodipine.
No, one
One
machine
needs a
can be
VE ECMO,
used.
one needs VV ECMO.
Uh-huh.
And ventilators were shared, but not the ECMO. How you can share
I
that?
think he is talking about the Centrimec machines. Yes, Centrimec machines has 2 consoles and different pump heads. So basically Centrimec was made for the VADs. So they are providing 2 consoles and 2 pump heads. So in that case, that is the scenario you can choose it. But remember the things, there will be no spare of hand crank or other supports.
The
So-
second machine is a backup. So if you use that machine and suppose one machine conks off, then you are left with nothing. Right?
Thank you.
Okay. So 60-year-old male, COVID, extensive COVID fibrosis and CT scan on VV ECMO day 140. Family counseled for lung transplant for last 2 months, but they are denying repeatedly. He is awake, alert, and well communicating. Repeated attempts for the weaning failed and now landed with a septic shock, which is usual course when it's a prolonged ECMO run. And now family wants that escalate to VA ECMO and do whatever more can be done in this patient. So my question to Dr. Dipanjan.
This patient's lungs won't improve. Extensive fibrosis has occurred. We have waited for 140 days, and it's without a transplant, it will be mostly a futile attempt. If we escalate support, first of all, escalating for VA for sepsis is not a good idea when the cardiac function is good. Secondly, supporting him in all the ways possible. Are we not prolonging the agony of the patient? That is a question that we have to discuss with the relatives. They have a emotional bonding with the patient. That is why they don't want to let him go. But unless we are going for some corrective measures to have a fruitful life for the patient, just continuing therapy for the sake of increasing, delaying death is not a good option.
Sir, Dr. Puvani, sir.
Agree with the views of Dipanjan, like this has been a prolonged ECMO so far, 140 days, and family is counseled, they have denied repeatedly to go for lung transplantation. The factor here is patient is awake, alert and communicating, so as a physician also, you might feel like if the family agrees for lung transplant, maybe he has got another way of managing him. So in the way, as this is septic shock, maybe alternative therapies such as treating the sepsis or using cytokine removal strategies, cytosol, like that, they can be tried as an intermediary strategy if patients can afford that, family can afford that.
So what can be done? Suppose there is a situation that as a clinician you are not willing, even family is not willing, but patient is conscious and he is saying that I want to continue ECMO. So Dr. Kapil, what you will do in this situation?
So first, as we thought in theoretical part, where we can use a ECMO to bridge, means bridge to transplant, bridge to recovery and bridge to decisions. 3 points are there. So what is the point here? Bridge to transplant, it is there, but family is not willing. Bridge to recovery with such septic shock, and if we introduce the VA ECMO, definitely it is not up to a recovery because lungs are already bad. Bridge to decisions, of course, there is no point to discuss it here. So in this scenario, I'll continue with the VV ECMO. Same times in VV ECMO, I'll introduce a CRRT or cytosolve therapy where these are a superior modality than the VA ECMO to support the septic shocks. So my goal will be continue with the VV ECMO as families want to continue, and same times ask and take opinions of expert transplant teams, and same time start counseling and documenting all your notes daily basis. That is
Dipanjan, any other thing you would like to add? Because now what the situation is, you as a doctor, you are saying it is nowhere situation, so we should not continue with the ECMO. Family is also saying, okay, we are ready not to continue, but patient is conscious and he's saying, I want to continue.
I will give you an example. There was a case in US where a small black child was on ECMO, and it was more than 120 days, and it was a futile ECMO. There was no end point. And now the family, the parents of the baby insisted that ECMO has to be continued as long as the baby is alive. At that point in time, again the hospital said resources are reaching an end and there is no point in continuing ECMO, but since the parents are insisting, then whose decision will prevail? So then the matter went to court, and then they said that even if though it was a state sponsored treatment, but even if the patient parents were paying, then also the decision to treat the patient depends on the physician, not on the relatives or the patient. So even if the relatives want to continue ECMO, but the panel of doctors says it is of no point, then the doctor should be listened to. So if in this case, if patient is willing also and they decide to continue, but if the medical team feels that it is a futile exercise, then their decision would be considered by court.
So probably more discussion with the patient that what is the distress in him, that in spite of knowing the outcome, still he is willing to continue. What is left in his life means, is he willing to survive for certain reasons? Probably we need to look into this, that why he wants to continue in spite of knowing it that I'm not going to make out. Then possibly the family, clinicians, counselors, they should look into this, that what is the reason. Is it only simply that I want to be alive, or is he having certain goals and that needs to be addressed so that his distress goes and possibly he accepts the reality and the actual outcome of his therapy?
Sir, if the patient wants to continue, the patient's autonomy is supreme. That is the thing that is above all of us, us as being the physicians, beyond the families. So that has to be respected.
Absolutely fine. This is what I'm saying. We need to understand that why, in spite of knowing the fact, patient is still willing that I want to continue. So we need to look into this, that why, and patient autonomy, definitely it has to be respected. If he wants to continue, we cannot go against his wish. Yes, sir.
Adding a point, now you get another patient and you have only one machine, and after 140 days the patient says, I will continue, I will pay. But now another patient requires an ECMO and you got only one machine. Then what will you take a call?
Yes? Anybody from the house?
Sir, like sir said, the patient's autonomy is supreme. If, the relatives are secondary, for all you know, they want to kill the patient so that, the property can be, inherited. And
that's very true.
I don't think if the patient willing to continue the treatment, he should be, put supreme above all doctors' opinions for that matter.
Yeah, we all agree on this. There is no doubt about it.
And the second question, the patient is paying, sir, already. Patient is paying. So the patient, if he has bank balance, like
This is why I said
the patient is a billionaire. He's willing to pay. I
there
think
is
that
no
should be
single
respected.
answer. And do you think that can we buy life with money? We cannot. We can buy treatment, we can buy comfort, but we cannot buy the life, whatever we do.
As long as the patient is alive, I don't think it is within our right to deny.
I fully agree with you.
And on
I'm
the
not denying your thought.
And the second question, sir said, the patient, you cannot remove somebody's machine and give it to somebody. At least that is what I think.
That was a common scenario. Forget about the ECMO. That was a common scenario even during COVID time.
During
Think
COVID.
about the ventilators. Have you ever removed the ventilator for sake of another patient? No, answer
Never.
is no.
So you are right. You are absolutely right. This is what all of us will do. And that's why, but see what comes after this discussion, that probably we should, as we do routinely in ICUs, this patient needs ventilator, we have to put in on ventilator. Probably we don't counsel beyond this, but we need to think, rethink and arrange ourselves for making a appropriate counseling at every stage, not just at the time of a start of ECMO or just for the financial impacts. We have to keep all these things in mind, because at any stage a patient is recovering and suddenly one fine day you find that he is having an intracranial hemorrhage, and the family was happy that in 2 days you are going to, and you are telling that okay, he is recovering, we are very low on ECMO and possibly in 2 days ECMO will be off, and suddenly patient has ICH. So as a clinician, as a ECMO physician, we should know in what situation, how we have to talk, what we need to discuss, and all these things actually needs to be discussed with the family whenever we are running any ECMO in any patient, whether it's a VA ECMO or VV ECMO. And there is no single answer for anything. It all depends upon situation. Who is sponsoring, families addressing issue, patient is conscious, patient is not conscious, patient is, it can be other way around also. Patient is not willing to continue ECMO and family is saying no, we are saying that now how will you take off the ECMO? Can you take off without the family, even family wish? Because they are going to give consent. So it is a very challenging thing, but here comes the role of counseling. You need to understand why they are so resistant that ECMO should not be out. And you need to tell them that this is a futile exercise, that this is what needs to be addressed at the beginning. Because on day one, when you are initiating ECMO, the family is listening you, they are understanding it. But from next day onward, they will not listen you. They will look you suspiciously, that when you say that there is a problem, they feel that you have done something wrong. So that is why the counseling at every stage, probably twice or thrice in a day, especially for ECMO patient, becomes very, very important. So another case, 29-year-old male, morbidly obese, severe viral AIDS, non-responder to the proning and high mechanical ventilatory support, shifted, rescued on VV ECMO. So lungs are still white on day 21. Families from a village, and they were arranging money from the village people and relatives, and they had nothing to continue the treatment. Now what to do? Dr. Kapil.
In a corporate setup, it is a very difficult task. If you are in a government setup, it is a different scenario. But after COVID, we all learn about some other ways to find some financial issue with the crowdfunding and from the other sides also. In fact, nowadays there are some agencies which people are visiting from that agency to our corporate hospitals. If you have such patients, please provide the data. We can collect the crowdfundings also. So that is the one option here. But 21 days, I think, and it is a young male, I think we should contributing if it is needed from a, we have to talk to our management also sometimes, because already patients has paid for 21 days. So there are certain norms from which sides we can work is, one is crowdfunding. Second, we can ask the management to reduce the bill if it is needed. And from the doctor itself, from the doctor community, for the ICU staffs, we can contribute to support such patients. That are the ways. But we should continue, in my opinion.
Dipansha.
We can curtail our costs also. What we usually do is we reduce our investigations to a minimum. ABGs to a minimum, maybe once a day or twice a day. After so many days, usually the patient is more or less okay, stable. If there is doing the bare minimum investigations, main cost is with the antibiotics. What we try to do is we ask the medical representatives to give us samples so that we can give the antibiotics for free. That way we can cut down the costs, and it all depends on the hospital management, how much they can waive off the ECMO charges. That is where the main cost comes to finally.
Pubani sir.
On the same steps as my colleague suggested, our relationship with the hospital administration is also very important in certain scenarios. It is not the only scenario. More often we do come across these sort of scenarios, and we should be prepared. And one stage we are responsible for the patient, and ethically we don't want to stop the ECMO. We want to continue with that. But as it is final, we all know how much it costs for running the ECMO. Once the initial setup is done, patient is cannulated onto ECMO, and then it is the daily run of ECMO. So it shouldn't be costing many thousands of rupees per day to continue that. So in the same terms as my colleague stated, we can bring down the expenditure and have good relation in view of your relationships with the hospital administration. You can try to bring down those costs also. Meanwhile, crowdfunding, some sort of resources for continuing in such situation should help.
Dr. Goel.
See, every consultant has multiple attachments. Few are charitable centers, few are maybe one or two government centers and corporate attachments. And as Dr. Pubani said, that the cost of ECMO is only in the initiation. Then you can spare away with your consultation charges, the hospital bed charges, the ICU charges, cut down the investigations, maybe try to arrange for medicines at cost prices and other things. So all these things all depends upon your Robin Hood course, or maybe your involvement with the patient, that how much you can do for the patient. All crowdfunding will take some time to reach the patient, but if you find that your corporate hospital is not willing to come down on the cost, you shift the patient on ECMO to a charitable place where the cost factor will come down like anything. So in that way, I mean, if I have to give an example, I would say that during COVID times, many patients who were burnt out with the cost in corporate hospitals, we offered them, we will charge you nothing for ECMO. You just come to our hospital and we'll only take charge for the medicines. So therefore, the entire cost of hospitalization, ECMO, manpower were not charged, and they only paid for the medicine. That is how they continued ECMO for the further course, where they would have otherwise ended the ECMO abruptly. So maintaining a ECMO after initiation is not a cost. So it can very well be supported.
So besides this, actually a close clinical monitoring so that you can run your oxygenator for a longer time, because when we talk about ECMO cost, it's the most costly thing is the oxygenator. And if you adjust your flows, you are monitoring it regularly, your anticoagulation management is good, probably you can extend it few more days or much longer than that. And all of us has experienced that we continued one ECMO circuit for 40 days or 50 days, or even Dipanjan probably more than that even? More than that. Yeah. So, because ultimately it is the cost of circuit only, and rest all you can cut short. Besides this, you can think of any ECMO survivor who is capable of supporting this patient. You can always talk, because you are always in communication of those patients who are survivor. And in reality, this patient was other way around. We knew it that this patient is being supported by the villagers and other family friends, and we, after 21 days, we asked them that it is difficult for his recovery, but they continued. And we also tried from our side to cut short the cost as much as possible. And ultimately he was off ECMO on day 14th and finally discharged after 2.5 months from the hospital. So another case, I think last case, 65-year-old male patient was brought in emergency department with cardiac arrest. As per the relative, he had the chest pain and just at the gate of the emergency department, he was conscious and suddenly became unresponsive. The first identified rhythm was the asystole. After almost 20 minutes had passed with the high quality CPR, with twice he had a VF which was defibrillated, CPR is in progress. And relative were aware about ECMO, since one family member survived on VE ECMO due to sulfurous poisoning with few minutes of CPR prior to VE ECMO. And now they are insisting that you should go for ECMO. So my question to Dr. Goel, what he will do?
If my team is competent, confident and quick, because after 20 minutes of CPR, another 20 minutes would be minimum required to initiate an ECPR. So if I am ready, because ECPR requires a lot of experience and expertise, so I should be, if I have to take the challenge, I should have to be well prepared. If I find if I am going to take an hour's time in mobilizing everything and all the things are not in place, or I am not at the best place where I am effective, then I will not take a call.
Okay. Puboni sir.
I agree with that. He is eligible for ECPR, but it is at the center's responsiveness. 20 minutes, in the next 20 minutes, if we can prepare and put him on ECMO, that is reasonable. CPR has to be of high quality CPR. That is, output should be maintained well, blood gases, to make sure acidosis is not exceeding the limits, and do whatever you can to continue with high quality CPR. And if the center can make it, yes, it is a possibility.
Dr. Deepanjan.
Time is a factor. If we are late, then outcome will not be as good as we want. So already 20 minutes have passed and then we are calling for the ECPR team. They'll take another 2-3 minutes to arrive and doing everything another. We all know that ECPR is best if the patient is on pump within the first 40 minutes. So if that is the target, if we can achieve it, it is okay. Since they are already knowing about ECMO and know about the cost, so cost will not be a big matter here. And the problem occurs in the other scenario, where patient has arrested in the ER, convincing the relatives who are not aware about ECMO and going for an ECMO in that situation is difficult. What they say is that मेरा पेशेंट तो मर गया था, आप लोग ने पैसे लेने के लिए इनको ECMO में डाला हुआ है. This is the most common scenario that we face. And if the patient does not have a good neurological outcome or does not show signs of life, the laymen only see signs of life as moving, opening eyes or obeying commands. If those are not there, then they think that the patient is dead. Whatever you show in the monitor is a false, and you are just taking money from us, fleecing money. That's why you are put in there. That's the biggest problem that occurs. They don't pay after that.
Kapil?
I totally agree with all the points which colleagues has given. Only one input here is families knowing about the therapy, has aware about all the things.
Their expectations are high because they have seen the survival, and this is not the same situation.
But we should counsel a audio video with the family already 20 minutes. Time is crucial, so you have to mention about the neurological outcome particular. And again, in the same breath, you have to counsel them even within 72 hours if the patient is not opening eyes and he is not maintaining his neurological outcome properly, then there may be, we will withdraw this support. That is a very important point here. We should counsel the family, and same time we have to note it in our history also.
These are the valid points, because when we talk about the ECPR, the outcome is always bad as compared to the any other ECMO situation, and it is 30 to not more than 35% in all situations. And moreover, the first identified rhythm is the asystole. So no flow state, how much is the no flow state, we don't know. They are saying at emergency gate he has collapsed. So it can be 1 minute, 2 minutes, 5 minutes, we don't know. And he has not shown a single time the organized rhythm, only ventricular fibrillation twice. So there is a possibility that you may land up with a situation nowhere. So starting from ECMO indication, if we talk about indication, yes, grossly there is an indication to start ECMO. But with certain contraindications like initial rhythm identified as asystole, you are not aware that how much time of the cardiac arrest is there. So you have an indeterminate neurological status. And then coming the running ECMO, so you have to continue it for next 24 to 48 hours, and you have to, if family is insisting, and then you should be clear at this point of time that we may land up with the situation of ECMO nowhere, and we have to withdraw this support when patient is not recovering neurologically. So this is what 3 areas when we should think whenever we are initiating ECMO: indications and ruling out contraindications. We have to be clear and sure about it when we are initiating. We have to look for maintenance, that how what can be the ethical issue in maintaining, which includes most of the time the finances, our uncertainty, because again ECMO is not a treatment. And third most distressful situation is withdrawing support with the non-recovery, that there can always be conflicts. There will always be a distress in the family, and they will have questions. This may be financial, this may be just losing in the faith, because most of the time they say we have never been informed about it. So at every stage probably communication, and one thing is very, very important, that you communicate with the few members of the family, not with every member. Because what happens on day 1, some other relative, day 3, some other relative, day 7, some other relative, and he's telling, I have never been told anything. And you start from 0, and it is of futile because he will not understand anything. So it is better in the beginning you discuss that you choose 2 or 3 or 4 people, and I'll be talking with these people. Involve the doctors. If the family doctor is there, always involve, because probably they can be a good help. Family will listen them, and it may be easy for you also to communicate to the doctors in the medical language. He can understand you better. So these are the few points which can make your life simple in the ECMO run, especially when we talk about the ethical issues or communication issues or consenting issues. Sir, anything to add?
Yeah, sir. Thanks, Vivek. I just want to mention a couple of things. We did in real life situations in a government facility where money is not a problem at all, we did come across the following problems, which are sort of religious issues. We were in a situation where we were made to wait for Ganga Jal. People had confidence in this, and they said this is going to definitely sort out the issues, and yes, on further communications with the family, we did wait for satisfying the family. Cases of Jehovah's Witness, patients need to go on to ECMO, but family says you cannot use the blood or blood products. As per Islamic principles, as long as the heart is beating, you cannot stop life support. If you continue ECMO in a case of severe intracerebral bleeds or so, it is not in the patient's best interest. So these are some of the things which are very difficult to treat, and you need help from experts and religious personnel supporting us as well in these situations. Lastly, I have come across institutions which started doing ECMO without any experience. We did come across this in the last 6 months when we were interviewing people. They said they started putting patients on ECMO because there is an ECMO machine available. Neither the staff are trained nor the clinicians are trained. So this is ethically not acceptable at all. We have to consider these issues, like what if our own family members are in that situation. So definitely after this course, despite the fact the subject we need to know is so much, but practically doing the things and knowing the problems is very important before we contemplate doing an ECMO. Thank you very much.
Any other comment from the panelist?
Sir, everyone starts at the one day or the other. So every center will have the first case one day or the other. Thanks for the ECMO Society of India, now we have a large network of people around us who are always willing to help us out whenever there is a time of need, like in initiation or in any time during the ECMO run. But maybe around 15-20 years back, that was not there. So people had to start on their own one day or the other, which is may not be acceptable now. So we now have a fellowship course. People are now trained. People are now more aware of the situation and when they can start. So second aspect, sir, I have one patient, a practical problem that I see. Patient is a 32-year-old female, was admitted in 2 other hospitals previously. First, she was in a government setup where she was becoming hypoxic, and then she was shifted to another private setup where she was intubated, prone twice but not improving, then shifted to our center for ECMO. She is a mother of one 4-month-old child and one 8-year-old son. Now, bilaterally lungs were white and we put the patient on ECMO. Initially, after 2 to 3 weeks, there was some improvement in the lungs, but not significant improvement. So after around 3 to 4 weeks, 30 days, we did a CT. So CT was showing initiation of fibrotic changes, and the lungs were not okay to come off. So we gave, we started steroids, and we gave for fibrosis we have given medications. And we repeated the CT after 2 weeks. Fibrosis has not reduced, it's increased. And patient is awake, alert, taking tracheostomized, taking food orally, doing all chores, physiotherapy, sitting outside, cycling, etc. All she is doing. She is not having any active sepsis. Now the patient is from a village and the relatives can't pay. What will we do now? The patient's lung may not improve, and secondly, they cannot pay. But the patient is awake, alert, mother of 2 children.
There was a case. So I think we should continue the ECMO because still there are hope. After the COVID era, we had learnt a VV ECMO can be tried for a few months also, not a single month. And repeat CT if doesn't show much of progress of a fibrosis. And if you see, if there is a fibrosis, we have to look at the percentage. How much lungs are involved because of that. If sometimes we do a lobectomy for the malignancy also and people are survive. So some portions of lung are still able to take a load of it. We should continue. As far as the finances is concerned, I think we had discussed what are other ways how to deal with that issues. But I think we should give a chance to her and we should continue with the VV ECMO.
So the fibrosis is extensive. The only hope is a lung transplant. The relatives cannot afford a lung transplant in our center. Then what?
Bhuvani sir, anybody from the audience? Any viewpoint?
The hospital waived off the ECMO charges. Hospital sat with the relatives said that you take off ECMO. आप खोल दीजिए, हम लोग ले जाएंगे, मर जाएगी तो we will take directly for death.
So here hospital has waived off the charges. So finance is not an issue.
But for transplant they don't have money.
Transplant they are not willing. So we'll continue the ECMO till all the machineries like pump, oxygenator is working. If there is a need of to be changed anything, we should think twice, thrice before changing any component. But till date, we should continue when the components are supporting to us. That is, I think, take home.
Continue ECMO till there is multi-organ failure.
No, she is not having any sepsis, no multi-organ failure. On the 60th day, we find clots appearing in the ECMO oxygenator and the oxygenation getting poor.
In that scenario, we should not change because
we can't change circuit
we can't
without the
change
consent of the
consent.
patient
Yes.
attendant.
Same thing. And second thing, see, ECMO is not like in ventilators. In ventilators, as per the Indians guidelines, we can't remove till the heart is beating. Here, ECMO is not in that era. So here, if patient is not affording, if we see the outcome is not there, we can discontinue the ECMO supports. We'll continue such patients on the ventilator till the heart is beating.
Because
See, we
ECMO
do
is not
even
a standard of care.
Standard of care. Because what we do in other septic patients also, we see if the outcome is not good, we tell our staff, do not resuscitate much. We are not discussing too much of this part with the family, but amongst our core group, we can discuss it. We will not resuscitate much in such cases.
Sir, can I?
Yes, please.
We had a similar case. This was 58 days, a young 32-year-old guy, but slightly a different turn. The patient had a viral pneumonia, stuck. We were stuck. His lungs went into fibrosis. But since we kept on talking to the family, the wife got a feeling that the team was probably getting depressed and they didn't want to continue. So they stopped meeting us. They would say, Dr. Sahab, you keep on, saying the same thing daily. We are not stopping you. Why don't you continue? And it became a problem because then when the complications started occurring, and we would call them to discuss, to do a multidisciplinary team thing, they just wouldn't turn up. What do you do?
We need a balanced approach. Because yes, I fully agree with certain family, they don't want to listen everything negative. So how I make my conversation, I always divide positive and negative thing in any patient, whatever has happened in last 24 hours or 12 hours or 8 hours, whenever I am counseling, irrespective whether it's ECMO patient or any other patient. So we have to talk comprehensively, and they should never feel with an assurance that we are just informing you. This does not mean that we are reducing our efforts for the treatment or commitment to the patient. We, as a doctor, it is our responsibility to treat. Along with that, it's a responsibility to inform you the correct situation of your patient. So if suppose his lungs are not improving, but his renal functions are fine, his cardiac functions are fine, no vasopressure, so far no sepsis. So you can talk about those positive things as well along with that, but for the primary problem that your patient, for which we have kept your patient on ECMO, he has not shown any improvement so far. And as per my experience, we do not, we feel that there is a least chance of recovery. And at this point of time, if you feel that they are having some trust issues in you, possibly you can offer them a second opinion. So these things, because when you break the communication, the most of the problem starts occurring. And the communication break happens because of few reasons, including the mistrust. If they don't have a faith in you, then definitely there is a problem. I give you an example. 38, 39-year-old male patient with the DVR who came us with the dengue myocarditis, with the runs of VT. And he never followed up after 5 years of the DVR surgery. We did a quick echo. We found that there was some resistance in the valve. So we were not sure it's arrhythmia is because of stuck valve, or it is because of resistance in the valve, or it is the myocarditis which is causing a problem. EF was just 10 to 12%. Almost 3-4 times CPR done. We took him to the cath lab. Angio shot was taken and we found that valves are okay. We decided to put him on ECMO. We put him on a VA ECMO, supported. He had a multi-organ failure on ECMO, renal failure, bilirubin went up to 26. Fortunately, we were able to come out of everything. Only CRRT was running. He was absolutely fine for almost off ECMO 6 or 7 days. And suddenly one fine morning, he had a sudden intracranial hemorrhage. So it was difficult to tell family, because just 2 minutes back he has spoken to his wife and this was his marriage anniversary. So it was so unfortunate, but you have to tackle the situation. It was very difficult to explain, but fortunately, unfortunately, it happened in front of the family members only, that he was talking and suddenly collapsed. But still, there is always a suspicion that you gave some other drug, it happened, so what has happened, why suddenly it happened. We were ready to discharge him, just to say that, okay, dialysis, only dialysis will be required for next 6 weeks or 2 months, and he'll be fine. So this kind of a situation can arise, and there can be a lot of conflicts, but you should be ready. And if you have counseled these things in the beginning, then possibly it will be easy. And that is why I said talk to 2 or 3 relatives. If the different relatives will be coming every day, it will be very difficult for you to communicate or handle this situation.